So, without further ado, patient-centered care, next-generation cancer care navigation with William Wood, MD, MPH. Dr. Wood, welcome. It's really good to have you here.
Thank you. Great to be here, Tim.
Well, let's see. We're going to, there's a more involved bio. We're going to let anyone who wants to read that with the slides, but we're going to let folks know that you're a professor at the University of North Carolina, Chapel Hill in the Division of Hematology in the Department of Medicine. Graduated medical school from Duke University in 2003 and completed your study of hematology with a hematology oncology fellowship at UNC in 2010. Senior medical advisor to the American Society for Hematology Research Collaborative, that's the ASH-RC, and medical director for the patient navigation at UNC Cancer Center, and most important to us, the medical director for education and outreach with the UNC Lineberger Cancer Network. Dr. Wood, welcome again, and let me ask you, before we get to our poll everywhere, what's one thing we should know about you outside of your professional bio?
Thanks, Tim. Appreciate it. It's really great to be here today. I guess it's on my bio, but probably the part I want to highlight is that following the retirement of my good friend and mentor, Dr. Tom Shea, I've had the pleasure of working with Tim and this team over the last couple of years, and I'm so proud of the work that they've done to develop this lecture series. So it's great to be here as a lecturer, I suppose, and good to be with all of you today. Maybe one fact that's not on this slide is that I'm actually a native Californian, although as you can tell, I've spent much of my professional career in North Carolina, and North Carolina is where I call home. So great to be here, Tim. Thanks for having me.
Great. Thank you, Dr. Wood. Let's see. Cancer care navigation is an important component in achieving good patient outcomes. We try to make these first ones softballs, and hopefully this one is. While we're waiting for folks to look that over, let me just put up our disclosures for our CME and for our CNE, and let's see how we're doing here. We can give folks 10 or 15 seconds more to make their submissions. It seems like they're doing all right so far.
Yeah, the great news here, Tim, is that we seem to have 100% correct response rate, which may mean that our work here is done.
Okay,
call it a wrap.
Oh, wait. but they need to get that credit. Okay. I'm guessing a lot of them are here for that credit.
Fair enough.
We've got to get to that 50-minute mark. So.
All right, fair enough.
You can go ahead and advance that slide. And without further ado, next generation cancer care navigation. Dr. Wood, I'll turn it over to you.
Thanks a lot, Tim. I'll take it from here. It's, again, for all of you who are with us today, it's really a pleasure to be here telling you about what we're calling next generation cancer care navigation. And I'd like to make the case today that there's a new way of looking at navigation in cancer care that we think has an opportunity to really improve outcomes and improve equity of cancer care delivery at scale. And this is something that our team here at UNC has been working on. Really excited to tell you about some of the things that we're doing and some of the theory that underlies some of that. But the most important thing I want to say as we get started is that what I'll tell you about today represents the work of a team of individuals. And what I'm sharing with you is really just as a spokesperson for, again, an incredible amount of effort that many people have put into this and are continuing to put into this every day. So my heartfelt thanks goes to the entire navigation team here at UNC Health and the Medical Center. What I'd like to cover today over the next hour that you're here with us are three primary objectives. The first is to identify informatics tools that can facilitate population-based cancer care navigation, what we're calling next generation cancer care navigation. Second objective is to talk about how this type of cancer care navigation, this new model, can be designed with equity in mind. And then the third objective is to put this in a broader context. What's going on nationally? I'm going to tell you about a couple ongoing initiatives that can support the development of this type of programming and, importantly, maintain its sustainability. And that's activity that's going on across the country and from a federal perspective as well. And we'll end with that. So I'll go ahead and launch right into this and to tell you a little bit about why we're even having this conversation today. The reason we're thinking about navigating in a new way, and the reason why I think this is going to be relevant to all of you who are here with us in the audience today, is that we know that despite our best efforts, we still have challenges in cancer care delivery here and everywhere. And the reasons for that, from a patient perspective, are multiple. One of which is that from a patient standpoint, care is fragmented, it's chaotic. Our patients who are coming to us with their new diagnoses or recurrent diagnoses are looking for stability and security, and they're looking for reassurance that they're going to receive the best outcomes possible, no matter who they are or where they come from, and that they're looking for consistency and a way in which we are bringing together the best evidence and the best data from the minute that they come to see us all the way through their cancer care experience and beyond. In fact, in current state, many of our patients feel like they're lost. It's an incredibly complicated, confusing, challenging system throughout the state, throughout the country, and frankly, throughout the world. And many of the reasons that our patients feel lost have to do with what we call non-medical barriers to care, also referred to in some contexts as social determinants of health. And these include transportation, childcare, financial strain, and other issues. And when there are these non-medical barriers to care and there are difficulties accessing routine cancer care from beginning and throughout the journey, this leads to problems that include delay in receipt of needed care, problems including reduced clinical outcomes, and unfortunately exacerbation of disparities, which we already know are a current problem in the cancer care landscape. Furthermore, our patients that are coming to us are thinking about where they're going to get that best care, and they're trying to evaluate what that initial experience looks like to help them make that decision. And while we might think about retention from the perspective of a healthcare delivery system or a practice, I'd like to think about this from the patient perspective as well. Because if a patient is coming to us or to anywhere and has an excellent initial experience in getting on the road to treatment, that's going to be the best possible pathway to shortening that time to treatment and making sure that that person can receive the care that they need. If there are problems with that initial experience and fragmentation of care delivery and kind of a little bit of uncertainty about where someone might want to go and how and when, that can lead to additional delays in getting that initial needed care. And we now have lots of evidence. As an outcomes researcher, somebody interested in healthcare delivery research, I know, and many of us know very well now, that there are a variety of supportive care services that have been developed for patients throughout the cancer care journey that lead to better outcomes, including palliative care, psychosocial care, physical rehabilitation, nutrition, and many others. But the issue is that these services remain significantly underutilized. Lots of reasons for that. And one potential reason is that the referral process to these various services is unfortunately, in many instances, not coordinated, standardized, and centralized. And that leads to missed opportunities for our patients to receive some of these types of supportive services and therapies that they may well benefit from. And that leads us to how we're thinking about, why we're thinking about developing a new model of navigation. The idea here is that we know that in many environments, including our own, we do have cancer care navigators, but we recognize that to really make our navigation workforce even more effective, additional resources may help. In particular, a centralized navigation program that allows us to look at not only patients that are coming through in a reactive way as needs come up, but actually taking a bird's eye proactive view from a population perspective, the whole population of individuals that we see here or that other centers may see as well, so we can figure out how to improve outcomes through healthcare transformation. We do this by trying to better understand which patients might benefit from which services, and we do that by trying to identify risk for various concepts, which might mean risk for adverse health outcomes. It might mean risk for having significant unmet need burden that we're going to try to address in the best way possible. And the hypothesis is that by developing a new model of navigation, we can actually develop structured pathways to limit variation and improve equity and reduce disparities in care across the entire oncology care continuum. And that leads us to what we've been doing here at UNC Medical Center. This is illustrative. I think that, as you'll hear towards the end of the talk, there are other programs that are doing things like this. And so one of the reasons to put this model forward for all of you to hear today is to hopefully get the wheels turning and think about how you might think about doing similar types of things in your own healthcare delivery settings. So what we're doing is what we're calling our central navigation program, and that complements, again, our existing clinical navigators. And our centralized program actually has a few features. One of these features is that we are trying to develop a standardized approach for early and frequent outreach to all the patients that we serve. Of course, we have to start within a particular population. Then we're looking to scale these services across the entire cancer patient population here at UNC. To do that, we've developed a central cadre of individuals which have some new roles. We call these roles our oncology nurse navigators, or ONNs, or oncology patient navigators, or OPNs. I'll talk more about that in just a moment. And these individuals really interdigitate with our existing clinic navigators to really help hone in on some of these non-medical barriers to care and help with a lot of this outreach and these assessments using some of the informatics tools that we've been developing, and I'll tell you more about those tools in a moment, all the way through the trajectory, from presentation through treatment planning, through receipt of treatment, and ultimately through implementation of other services. We do this by looking at social determinants of health and collected in a standardized and consistent way. We do this through centralized pathways that bring our patients to different types of referrals that they may benefit from supportive care. And importantly, we're leveraging incredible work that's been done here at our medical center by Dr. Ethan Bash and colleagues, and now internationally, around illustrating how the patient voice can be brought right into cancer care delivery through the collection of what we call patient-reported outcomes, in this case, symptom surveillance, social determinants of health, and other unmet needs assessment to help provide the best services to the best patients at the right time. Just to give you a sneak preview, I'll show you a little bit more data about our scope in just a moment. Over the last fiscal year, we were able to reach about 2,000 new patients, and with the centralized program, provide about 5 touch points per patient and 10 navigation interventions per patient along the way. I touched for just a moment on these new roles. So this gives you a sense of these navigator definitions within our centralized program. These definitions have been intentionally designed to align with the definitions that are being used nationally. We have a wonderful cadre of volunteers. These might be community or student volunteers who can help with barrier assessments and provide emotional support. And then increasingly, the linchpins of the program are these 2 additional new roles I referred to before. So just by way of vocabulary and context, what we're calling oncology patient navigators are actually individuals who are full-time staff members. They're typically highly trained professionals. They work directly with our cancer patients, and they help identify and decrease non-medical barriers to care, again, using that population-based bird's eye approach. They can help to identify other specialty services and other supportive care and resources that our patients may benefit from. And importantly, here I'm talking about both at our own medical center, but also out in the community and even nationally. Patient advocacy organizations, Leukemia Lymphoma Society, and others like that. And oncology nurse navigators actually have registered nursing licenses, and they bring that clinical perspective to help with escalation of needs that are identified by our oncology patient navigators, as well as other specific services for our patients that require additional clinical insight and nursing background to ensure that the care they receive is meeting all of their needs. Just a quick schematic to show you a little bit about what this looks like from sort of a credentialing and training perspective. Here you can see our volunteer patient navigators on the left, and as you move to the right, you can see that our oncology patient navigators really have many to all of the same criteria as oncology nurse navigators, absent specific nursing licensure. And their focus and education is largely on the non-medical issues. And then on the far right, you can see our existing personnel, our clinical nurse navigators that work in the clinics every day. So I told you a little bit about why we're doing this, told you about some of these new personnel that we've been bringing on board to help deliver these services. Now just a snapshot of what this model looks like as we've been implementing it. We start again from the moment of referral, from intake, and then we begin to engage with our patients through our centralized services, through what we call the pre-consult period. And I'll tell you more about this in just a moment, but essentially what we're doing is structured, standardized outreach. We're getting to know our patients early while they're still kind of getting to know our system. We're learning as much as we can and in their own voice and having them tell us about their social determinants of health, different features related to sociodemographics, their clinical, social, and medical backgrounds, helping us to really have a very clear, comprehensive understanding of who they are, how they're coming to their cancer patient experience, and how we can best help them, and how we can communicate this information to the teams that will be helping to be involved in actually delivering their clinical care. This brings us into our pre-treatment phase for those patients who do decide to stay with us and receive cancer care, and we're able to actually do a few things at this stage. One is actually implementing some of these centralized referral pathways that I had noted. So through structured data, you'll see this, both coming from the electronic health record, as well as through these structured telephone assessments. This can help us to identify certain resources that we think patients might benefit from. And even before or even alongside the clinical care teams that are seeing our patients in the clinic, we can, from a central perspective, actually go ahead and provide those resources directly to services that patients may benefit from, again, either right here at the medical center or potentially externally as well. Now, I'll talk about a really exciting pilot program that we're just getting going now and about to scale. It has to do with these patient-reported outcomes that I'd mentioned before. We have a way of identifying individuals who we find to be at high risk of experiencing adverse treatment-related outcomes. We call these unplanned acute care events. Talk about that soon. And those patients actually come into our PRO program and actually end up getting regular outreach through our centralized navigators with escalation pathways to other individuals at the center that can provide provide support for emerging needs and toxicities. That continues all the way through active treatment. Our program continues to provide these sort of weekly or less frequent check-ins or tuck-ins to ensure that social and medical needs are being met at every step along the way, and then into survivorship. So I mentioned that we already have been reaching about 2,000 new patients. This just gives you a little bit of a sense for some of the data associated with the program so far. I talked about that pre-consult space. That pre-consult space includes something that through these structured, standardized phone intakes we're calling our pre-consult assessment. I'll give you a clue to a couple of different elements that are in that pre-consult assessment. We've already done around 1,200 of those so far, and those numbers are growing over time pretty significantly. What those assessments allow us to do, in addition to the other structured assessments that we perform, including our pre-treatment assessment, after-treatment assessment, and then these check-ins, is that we help to surface these unmet social and clinical needs. And when we do that, we actually are able to develop and implement navigation-related interventions, of which we already have delivered over 18,000. These might be around education, around treatment regimens, anticipated side effects, but they also have to do with these specific referrals to pathways or even direct interventions that can be provided over the phone, virtually, or in person. And this just gives you a sense that as we are implementing the program, we're moving through the various different disease groups that we're reaching here at the medical center. We're working with our colleagues at Rex to do this on a geographic basis through clinics at Rex. And ultimately, we hope to scale and implement this model in various other locations around the state over time. This gives you a little bit of a sense for our demographics so far. You can see that we have a pretty broad age distribution. And importantly, we're looking to make sure that we are really matching and reaching the anticipated sociodemographics from a race, ethnicity, and insurance perspective of those patients that we serve through UNC. As our program grows, we already are sort of beginning to expand concentrically in terms of where our patients are coming from as they're visiting us and receiving our services. And ultimately, the long-term goal is to make sure that we are reaching our patients and finding them and delivering services virtually to their homes, no matter where they live around the state of North Carolina or maybe eventually beyond. Early returns so far are that we think that this type of proactive population-based approach we think is making a difference. And what we're seeing already is that we have a reduction in the cancellations for our new patient appointments. We also have reductions in no-show visits. And then importantly, none of this makes any sense unless the people that they're working with, our patients and our providers and our navigators, those around the system really find that it's providing them with some benefit. And when we look specifically at the question of whether or not our patients felt that they were being prepared well for their first oncology consult, and whether our providers felt that their patients are being prepared well, we found so far that the early answers have been quite positive. And I think what this graph shows is that from the patient perspective, really quite overwhelmingly positive in terms of their level of agreement with the preparation for their initial visits here with our cancer care providers. I mentioned that we really are trying to design this with equity in mind, and I think what you can see here is that we are able to deliver these services, able to deliver interventions, identify risk factors, disperse funds, bringing dollars back to patients to help ameliorate financial toxicity and other concerns, and delivering important interventions regardless of race, ethnicity, or other sociodemographic characteristics of our patient population. So that's in a nutshell sort of how we're thinking about navigation and the very basic framework of what we're doing. What I'd like to dive into now is to kind of look under the hood a little bit. I want to tell you something about how informatics is informing our approach, how as an academic center we are really trying to meet the mission of our center by embedding evidence generation, cancer care delivery research within this infrastructure that we're building, and then I'll tell you about some national programs. So let me just say a word about what myself and my colleague, Dr. Jennifer LaFada, and others are calling embedded cancer care delivery research. And the idea here is that we're actually bringing all these different components to bear on the care delivery side, this navigation infrastructure I've described for you. On the informatics side, our Epic electronic health record system, population health colleagues and Health Alliance and ISD, and importantly NC Tracks to actually bring real-time, real-world data in oncology so that we can actually understand our population better. We can develop interventions, deliver those interventions, and then study those interventions to see if they're making a difference through research infrastructure that we've developed through our clinical trials office in a pod that we call our cancer care delivery and aging pod. And this just gives you an example, a few examples of some of the different types of interventions that we're doing as we're developing this kind of embedded research. We're talking about how our navigation program is meeting unmet needs, and we're studying that in a formal way. We're talking about interventions that can help people prepare for care. We have a wonderful physiatrist, Dr. Sasha Knowlton, who's now part of our center, who's working on a cancer prehabilitation protocol alongside Dr. Chris Jensen, helping our patients prepare for care, and these are actually services that are offered routinely, in addition, including a centralized referral pathway that we have through navigation. We're studying how we're delivering treatment support, and I'll tell you about the PROs again in a moment. And we have a health coaching program that is built right into routine cancer care delivery. I mentioned our population health management group. This is a group that's actually working with us to build these informatics tools. And when you have informatics tools like this, you can identify patients in real time as they're coming into the center, what their needs might be, how we can best support them, how we can best target our services, how we can figure out where are the care gaps, how we actually are able to identify those care gaps, see those care gaps right through the electronic health record at a point of care view that our navigators can see, our providers can see, and others with access as well. How does that actually work? Here's a model that hopefully is, again, illustrative and helpful to those thinking about building services like this for their own healthcare delivery sites. When we're talking about a population perspective, what we're talking about is, first of all, using that universe of data that we're getting through our routine care delivery, which comes through the information systems we have. Those are our electronic health records. We develop registries through the electronic health records, and with those registries, we bring in structured information from certain types of outreach. We bring in information passively acquired through the electronic health record, and we use that information to help figure out who needs care, how, and when. In doing that, we are then able to actually implement those interventions, and then we have a monitoring structure and a reporting out structure that helps us determine whether or not we're actually moving the needle in the ways that we want to, and we can actually study that in a quantitative way. And to the extent that we're doing that effectively, that then leads to broader scaling of what we call practice transformation. And there are several steps that actually go along that build process from this informatics perspective. I'm going to use some terminology that's specific to Epic and to how we think about this. And you may have different terms for systems like this within your own local environments. We rely heavily on our clinical leaders, our oncology teams to figure out where the care gaps are, what the measures should look like. We work with our informatics teams to go ahead and share the specifications of those measures. We figure out how they can be built into our EHR environment, which is Epic. We validate those measures, and sometimes that means coming right back to our navigators, our clinicians, others, to make sure that the measures are working as they're expected to work. And we call that measure validation. And then if everything is working appropriately, we bring them into dashboards. And those dashboards can be hosted on a variety of different platforms, but they include the ability actually to be viewed from within the EHR and made available to different users with different types of permissions. Here's a few examples of how we're actually bringing quantitative data to inform the care that we're delivering. I'll give you 3 examples. I'm actually going to dive into a few of these in a little bit more detail. One of them relates to how our navigators are collecting information on social determinants of health and bringing in information that's passively acquired through the electronic health record. So the idea here is that we've identified the elements. We figure out how to source those elements. We work with our partners in informatics, in this instance, Population Health Management, Health Alliances, Information Services. With their assistance, we develop a brand new composite score. We call that our navigation assessment score. That navigation assessment score gives us a number, a risk stratification for where we think our patients may have unmet needs and who is likely to have the most unmet needs. And then based on that, we can then develop an intervention, which in this instance has to do with the frequency of follow-up of our navigation program and the types of services that we deliver. Another example, we can go directly to patients and we can identify, again, what are the right elements. So we figure out what symptoms we want to follow, how we want to follow function, social function, physical function, psychological function. We identify informatics partners. In this case, we have a homegrown patient-reported survey system called Procore. We have a visualization platform we work with called Chai, and this is what our coaching program uses. And we have quantitative outputs, so we can follow on dashboards, use that information to inform how we're actually delivering coaching on a week-to-week basis in a tailored manner with our patients. And in process is this development of what we've called our acute care event risk score. Who is at the highest risk for unplanned ED visits or hospitalizations? We've identified a model that we believe predicts this well. We figure out what the elements are in that model. You can see them listed here on the left. We have our informatics partners again. In this case, we work with NC Trax and resources we have here through Lineberger. And then with that risk score, we're now going to figure out how we're going to identify certain types of interventions, either existing or new, patient-reported symptom surveillance. I'll tell you about a really exciting project we're getting going with our UNC Advanced Care at Home team to bring care to patients how and when they need it. And these are examples of tools that we're bringing right in within our navigation program. I referenced the navigation assessment score, just to give you a sense for how and when we're using that. We're doing that before patients come in for their first consult visit, and again, as treatment is initiated. This brings in clinical and social data that predict unmet needs. We have a measure that we call our time to treatment monitor. The idea here is that we're using one of several different triggering events to help figure out when patients ultimately would become eligible in some fashion for treatment. And then we're able to follow them prospectively going forward and trying to figure out who's getting lost. Where do the disparities exist? How can we get patients to treatment in a more rapid fashion? And then the acute care event risk score that I just referenced. We're using these various factors, and we're using that to directly deliver different types of our navigation services, including our PRO surveillance and potentially our advanced care at home partnership. Here's a deeper dive on that navigation assessment score that I referenced. Gives you just a little bit of a clearer window into kind of what it actually literally looks like from the user perspective. So what you can see here is that a patient has had data collected through the EHR. They've had data collected through this structured telephone intake, and those data actually are brought together in a way that's made transparent to the end user. That's what that table at the bottom on left represents for you. You can see where this particular patient may have acquired points based on a variety of different factors. It could relate to age, race, ethnicity, social determinants, social vulnerability, zip code through geolocation, and a variety of other factors here. That actually feeds into a composite score. That composite score fits into a low, medium, or high risk category that is color coded and gives somebody a quick glance at like who needs help, how and when, and then it informs the subsequent delivery of our navigation services. Our time to treatment monitor has been built. It's being tested right now. We're starting with our GI group. The great thing about having this proactive navigation program is that we're actually able to work with that cadre of navigators and our clinical navigators to do that validation work that I was discussing. How well do these 5 triggering events work? How useful is this information in regular practice? How should we be adjusting this so that it actually helps our patients get to treatment in the best and most rapid way possible? Part of that, of course, is building tools that our navigators can use in a way that makes sense, and that involves developing reports that are available right in Epic to help to deliver that care. Okay, I think I'm on time. I know I'm presenting information quickly, so bear with me. I've got just a little bit more to get through, and then we'll get to our Poll Everywhere questions. So I talked about that acute care event risk monitor. So now I'd actually like to take a little bit of a deeper dive into talking about why we're focusing on this and what this pilot that I was briefly alluding to with our advanced care at home team might look like, and what I think is really going to be a truly innovative service offering, not only here in the state, but nationally as well. So why are acute care events an issue? Again, just to level set, here we're talking about unplanned emergency department visits and hospitalizations. We know abundance of evidence supports from our patients, our families, caregivers, that I'm going to call these ACEs for acute care events, but ACEs are significantly associated with poor health-related quality of life and an impaired cancer care delivery experience. Nobody wants these experiences. And we know that some of these are, not all, but some are preventable with improved supportive care. And we know from a population prevalence and incidence perspective, this is a big deal. We see ACEs and high-risk cancers up to 30% of the time. And this is especially prevalent as well among patient populations that we believe are marginalized. And so there's an important opportunity here to intervene. We know that there are disparities across marginalized populations, that the UNC is no exception to that. And our hypothesis has been that if we can find a way to intervene on this, we're actually going to be able to improve tolerability of treatment. So that's actually really important from an efficacy standpoint. That means that our patients are going to be able to receive the care that they need and that they want for as long as they need and that they want it. And importantly, it means we're going to be able to increase the effectiveness of the care that we deliver. So let's just make this a little bit more real. And let's kind of give you an example. Fictional patient, of course. But consider for a moment Mrs. Jackson, 72-year-old, otherwise healthy woman who now has metastatic pancreatic cancer with weight loss, fatigue, and pain. She's widowed. She lives independently in Clayton. It's really important to her to spend quality time with her family, and she wants to see her grandchild graduate from NC State next year. The clinical team is, let's say that Mrs. Jackson has come through the navigation program. The clinical team is planning for chemotherapy, and we know that's not going to be easy necessarily to receive. And we have lots of questions, and this is really what we're trying to really focus our navigation services and our advanced care at home collaboration on. How do we know whether or not Mrs. Jackson's at high risk? And it turns out that she is, but how would we know that without actually being able to identify that in a systematic way? And if she is, how are we going to help her get through that care that she wants and that she needs in a way that is that makes the most sense and is tolerable as possible? If she needs help, how can we get her the help that she needs and that she wants in the home as much as possible? So to figure this out, we actually went to the literature, and by we here, I'm really referring to colleagues of mine who are not myself, who did this wonderful work, where they used a previously identified published model called PROACT. They identified additional characteristics that they found would predict 30-day risk of an acute care event, and these are listed here. And then we tried to figure out how to build this into workflow with rapid cycle tests of change. And the way we decided to do that was actually developing a patient-reported symptom surveillance system. That system, the build is actually well underway, and we're just about ready to bring our first patients through that program. So we anticipate that we're going to be doing this, again, I'll call it PRO surveillance, figuring out where there may be new, emerging, or concerning symptoms, doing targeted outreach with our navigation program to these patients that trigger alerts for these symptoms and helping to get them care as quickly as we can. Now, on top of that, we're actually working on a partnership with our UNC Advanced Care at Home colleagues to develop something that we're calling our Oncology Urgent Care at Home program. And here the concept is that not only are our navigators able to reach out to patients as needs arise, but we're actually able to bring additional services to the homes where patients live to help them get the care they need without even necessarily, in some instances, needing to come to the bricks and mortar care facility. And we believe that that approach is going to be associated with overall improved clinical outcomes. We can do this, we believe, because our Advanced Care at Home colleagues are running a program that you may have heard in other contexts referred to as Hospital at Home. This is an advanced infrastructure that includes mission control, monitoring, rapid response services, really anything that anybody would need depending on what toxicities might be developing in the home environment. And in this partnership, we're envisioning two models for delivering these services. One is what we call our primary prevention model. The idea here is that patients are coming through the navigation program. They are identified as being at high risk for these acute care events, and then we're actually able to enroll them into the program. And then as we're getting the patient-reported symptoms on a regular basis, if we identify needs, we're able to bring those Advanced Care at Home services right out to them and help them as they need it. In the secondary prevention model, on the other hand, we know that patients who've experienced one acute care event are clearly at risk for another. And so the idea here is that those patients who've already experienced an acute care event will be getting additional higher frequency, higher intensity surveillance for our navigation program. And then we're able to get those Advanced Care at Home services out to them whenever they need the assistance. This gives you just a little bit more kind of explanation for how that works and the frequency of the screening. To come back to the mission of an academic medical center and our desire to drive embedded cancer care delivery research, we have identified how we would propose to actually run a study, the way we can actually look at outcomes from this. And this would be a routine care delivery study, but we would carefully look at the types of things that are important from both the perspective of have we been able to move the needle in actually reducing acute care events with an appropriately statistically powered population sample? And then importantly, how is that actually being received by our patients, our navigators, our clinicians, and other parts of the healthcare delivery system? Okay, last few minutes, can tell you about a couple of national things, and then I'll wrap up and close here. So I had said at the outset of this discussion that I was going to be telling you about a lot of things that are happening here at UNC that we're really, really interested and excited in. But what I'm trying to convey is that this is a prototype. This is where we think next generation cancer care navigation is going to go. And as we look around the country, we see that lots of other programs are having similar ideas and thinking about different variations of this type of approach. And so we've been so fortunate to work with the American Cancer Society Cancer Action Network, which has convened a number of centers listed here on the slide from around the country who are interested in developing versions of these types of navigation services and working with each other to implement them and learn from each other in what we call a learning collaborative or learning community. These are some of the resources that have been brought to bear in this arrangement. These include actually the support to get this work off the ground. the learning community, and that's actually where we have our regular calls with each other and share data, share experiences, and learn from each other, and then develop ways in which we can sustain the program going forward. This gives you an idea of the kinds of components that we're thinking about around sustainability. Again, it's been a wonderful experience because we're trying to figure out not only how we can actually build, develop, and implement these great services, but how we can make sure that they're built to last. And we do that in part by talking with our colleagues from around the country, how they're figuring out these same issues and how we can learn from each other. These are the aims that our program has as part of this learning community grant. And you can see that they really touch on a lot of the topics that I've discussed with you already over the last 40 minutes or so. They use our tools that we've developed that help with our decision support, as I mentioned, the navigation assessment score, time to treatment, et cetera, acute care event risk score. We have rapid cycle PDSAs that help us make sure that we are implementing these tools in the right way, that they're making sense. Then we have an effectiveness evaluation. Do they make a difference? Then we look at the impact on our navigators and our staff. How is this contributing to job satisfaction, work engagement, burnout, et cetera? And then importantly, how are we going to disseminate this work? How are we going to ensure that this work is sustainable? And this gives you a sense for kind of how we're formally thinking about this from a evaluation standpoint in the context of the grant. We look at this from the perspective of what are the overall needs, what process measures are we using that our navigation program can collect with this real-time real-world data in oncology, what are the types of outcomes that we think that we are going to move the needle on, and then ultimately, how does it have impact on the types of outcomes that are most important to our patients and our families and our providers and the overall healthcare system. American Cancer Society Cancer Action Network has also been advocating for change at the federal level, and we think that this work will hopefully lead to the kinds of changes in Medicare and elsewhere that are going to help to make services like ours sustainable from a financial perspective. These include new codes, and I'll talk about that in just a moment. Principal illness navigation, hopefully, is going to get approved for implementation in the next calendar year, so watch that space for more, and we'll all be learning from each other about the best way to implement that so that these programs can be financially sustained going forward. Okay, a couple of sneak preview slides here as I close. One, I told you about all the great work we're doing now, and so a couple of things to think about in the future. There are some great Epic tools we're looking at, including Care Companion to provide a digital front door and a digital patient companion that really helps to deliver these services in a virtual way as much as possible for our patients. So we're in the middle of exploring that now. And then there's a project that you'll probably be seeing as part of the Epic Foundation available to all centers called ESIM. That's taking that patient-reported symptom surveillance that I mentioned and actually bringing it in a really appealing and effective way. It's already been tested at 6 different centers right into the Epic EHR system. And that's in the foundation build now, and you'll probably be seeing that in a number of centers over the next couple of years. Lastly, I referenced these navigation reimbursement opportunities. There's a new code that's been proposed, principal illness navigation, as well as some additional funding going to social determinants of health assessment. And then there's some existing codes that we're trying to figure out the best way to leverage for navigation services as well. And then as we go forward into the future, I told you about a lot of work that we're doing at UNC Medical Center and Rex that the health system is supporting. But ultimately, these are the types of services that we want to build, grow, scale, disseminate, so that patients throughout the state can benefit. And whether those are patients at UNC or patients in other healthcare delivery systems, we're hoping that what we have learned are lessons that we can share broadly with whoever is interested in this topic, so we can actually develop next generation cancer care navigation, meet all the needs of all of our patients, no matter who they are, where they are, or the kinds of needs that they have. So I know it's a whirlwind. I'm actually going to go ahead and conclude there. I think I've left maybe just a minute or two for our Poll Everywhere questions to see if anybody has been able to stay with me all the way through, or maybe if you're a good test taker, you'll be able to figure out the answer regardless.
All right, here, we'll go ahead and navigate to that. And while we're doing this, I realized we're in a new studio space, and so we're still getting used to a few things. And one of the things we need to do is I need to move my mic closer, but I'm also going to put my mic here. And Dr. Wood, I'm going to have you put your mic in the center because otherwise, so kind of closer to in between us here, so that way when we face each other to converse, we're not fading out from the mics. So, okay, great. So you want to go ahead and share this first question with them?
Sure, happy to. So the first question is, which of these statements is most accurate when it comes to the role of informatics in cancer care navigation? And I should preface this, of course, by saying, as always, there's no wrong answers. There's opportunities for discussion. So the first answer is A, most EHR vendors have a cancer navigation module that's easy to turn on and simple to use. And so far, we have 8% of respondents, 4% with that answer. B is local navigation approaches to data management tools are well positioned for long-term sustainability. And finally, a collaborative relationship among navigators, clinicians, informaticists, and a healthcare delivery system is optimal to develop navigation informatics tools that function well and are built to last. And right now, we have 97% of respondents who have chosen that answer, which is the answer I was thinking about too. So thank you to those 97%. For those who have chosen answer A, I think it's a very interesting and important thought. And I will say, actually, digressing for just a moment, there are lots of flashy tools that are out there. Lots of EHR vendors, of course, will say that they're doing great work in navigation. And I do believe that sincerely they're putting their best foot forward to do that. But I will say, if there's a lesson learned for me and our team through this experience, this is a team effort, and it is really, really hard to take off-the-shelf tech solutions to any of this. It takes a lot of really kind of in the weeds, on the ground, collaborative effort, including with local informatics experts and those in the clinic to really help make all this work. So I will say that EHR vendors often do have different types of modules. Whether I would characterize those as easy to turn on or simple to use, probably not yet. Hopefully one day in the future. In the meantime, it's going to take a team effort for us to get there.
Great. I'm going to say anytime I see an answer that says a collaborative effort or a team effort, you almost always have me there. You had me at C with the collaborative effort. Let's take a look at this next one.
Okay. What are some ways in which a centralized navigation program can promote health equity? Our first one is it might identify unmet needs in vulnerable populations through systematic population-based outreach. That's answer A. Answer B is reduce time to treatment by monitoring populations and intervening with those who need the help. And answer C is address disparities in unplanned acute care events through providing a standardized approach to population-based treatment support. Or D is all of the above. And it looks like so far we have, we've got, well,
2,200%.
Wow, that's really exciting. That's pretty cool work.
There we go. That looks better, 96%.
That reminds me of when I usually talk about being 1,000% in support, and that was clearly what happened here. So I would say that's right. I was thinking about all the above too, although I'm gratified that somebody has chosen option C. It tells me that all that extra time I spent on that topic, maybe it resonated a little bit. But this is what we're hoping to do, and we think equity is important for all of these reasons here. And acute care events certainly are part of that equation, and we think there's a few other ways to address that too.
Great. And thanks to the audience for jumping in and answering these.
Yeah, no, thank you so much. Great to have participation and people who are engaged. So what are some examples of initiatives or programs that are supporting availability and best practices and navigation at a national level? Answer A is the National Navigation Roundtable. In fairness, I didn't actually specifically reference that organization, but they work hand in hand with the American Cancer Society, so they're part of those last few slides. B, the American Cancer Society Cancer Action Network. C, Epic Care Companion. D, proposed CMS codes for navigation reimbursement, such as principal illness navigation, or E, all the above. And it looks like most of our respondents have chosen all the above, and that is indeed what I was thinking too. All of these examples here should be examples that are available to anyone, not just here at UNC, but elsewhere. And even if you're not a formal part of the navigation learning collaborative that I mentioned through the American Cancer Society, ACS has a variety of wonderful resources that can help really any navigation program kind of get on its feet and figure out how to deliver the kind of care they want to.
Great. Thank you so much. And thanks to our audience. Now we've got at this point, and I just need to go back so that I can moderate this. Bear with me for just a second because there we go. Let's take a look. This is where you can go ahead and submit your questions, and we'll get to as many of those as we can. I will try not to monopolize because I made a big list of my own, so I'll get started with one or two of those, and then hopefully we'll see you in the audience going ahead and sharing your questions with Dr. Wood, and we'll get to as many of those as we can. Talk a little bit more, if you would, about the distinguishing the roles between, we've got the volunteer and then we've got the patient. We've got the volunteer navigator, the patient navigator, and then the nurse navigator. Probably most of us are a little clearer on the role of the nurse navigator, but could you help us distinguish a little more between the volunteer and patient navigators?
Yeah, thanks, Tim. Really appreciate that question. And, first, for those in the audience, I recognize that I really ran through a lot of topics, pretty fast-paced there. So I would encourage, if there's anybody who's interested in any of this and wants to follow up, getting into some of these details, like the question you just asked him, please do reach out to me afterwards. And if you don't have my contact information, we can definitely provide that. Happy to share with you anything that we've discussed on that topic. So I'd actually, at least as we're envisioning it, even think of this as 4 categories currently. So we have our clinic navigators, and those are those traditional individuals in traditional roles that many are used to. People kind of right embedded with the care teams in the clinic, helping to provide navigation services. And then we have these 3 new roles, or I would say newly defined roles, one of which is an oncology nurse navigator. And so, as you pointed out, Tim, that is the term nurse navigator is a familiar term, but as we're using it, we actually bring this into our centralized context.
Okay.
So that these are going to be the types of services that we can deliver that really require clinical input. If those are, issues around symptoms, for example, or other background clinical issues that need translation, bridging, backup support, or certain kinds of service delivery, our ONNs can really do a lot of that. Now, the OPN, OVN distinction is a question that you asked. And the nomenclature gets confusing. But here, when we talk about oncology patient navigator, to be clear, we're not talking about people who are patients, but rather they're navigating patients. And their background it just means that they almost always have some type of healthcare background in some capacity, but just not that nursing license. And importantly, they're not volunteer in that they actually are part of the team on a full-time basis.
Okay.
As part of full-time paid staff individuals. Of course, our oncology volunteer navigators are an integral part of our team as well, but they may come in and out depending on their particular commitments and other types of things that they're doing or working on, and the types of roles that they're able to fulfill without getting too deep into the weeds has some distinctions in terms of levels of access to the information systems and the types of things that we think are safe and appropriate with regard to patient care interactions and experiences.
Gotcha. And just to follow up with the oncology patient navigators, what would be some examples of the types of titles or degrees that they might have?
We've had individuals come from a variety of backgrounds, including social work, recreational therapy.
Right.
Many times these are individuals that are have been working with patients with cancer in a variety of different ways, but just not necessarily under that sort of nursing framework.
Okay, thank you. We have a question from the audience. Where do you see the potential growth of navigation in North Carolina?
Yeah, I love this question. Thank you for asking it. And something I didn't touch on because in part I was going so quickly through our own material is that navigation, really broadly defined, can mean even more in scope than what I talked about today, which is really kind of embedded clinical cancer care delivery navigation. And we know there are other really important types of of navigation that exists when it comes to screening services, for example, or when it comes to other community-based delivery of navigation programming for patients and families impacted with cancer. And I just mentioned that because I really wanted to make particular mention of our Office of Community Outreach and Engagement. Jennifer Potter and her team have been doing a wonderful job really bringing together the different types of navigation programming that we have, not only within our a care delivery infrastructure, but also across the School of Public Health, other parts of the institution, and importantly, entities outside of UNC that we interact with as well. So when I look at potential growth of navigation, I'm looking at that entire kind of spectrum of navigation services, from prevention to treatment to survivorship. I do think there's a need here for some kind of common aspirational goals and definitions and nomenclature. So I think that as we kind of develop that framework further, we can really make sure that we're getting into communities that are traditionally untouched by these services. So when I look at growth, I'm looking at meeting unmet needs on a broad statewide scale.
Great, thank you so much. Let's see if we've got. Okay, that's something else. I'm going to move your mic a little bit. We're going to bring it right there. We go. Well, as I said, we're still getting used to this. So you mentioned and I was really impressed with the attendance of patients at appointments, and we've had some discussion around that with the ACCURE study at another time. Can you talk about some of the strategies that you used that you found effective in terms of patient adherence to appointments?
Absolutely. I think probably one of the most important parts of that is having a warm, welcoming, friendly presence, somebody who's able to establish that human connection right off the bat, and importantly, somebody who is really able to demystify a lot of the process, which we know is incredibly confusing and complicated for our patients with cancer. Just thinking about adult learners, for example, I'd imagine that most of the people who watch the presentation probably have taken home maybe 10%, 15%, something. And, when someone, and many of us have been touched by cancer, have family, loved ones, friends who have been touched by cancer. And we know that those early days are incredibly, incredibly complicated. So I think having someone to say, we're here with you. We're going to help you figure this out. We're going to help kind of point to the kinds of things that you might benefit from, that might help you in this journey, really gives a lot of sense of reassurance and support. Helps get people kind of really tucked into that first appointment that they ultimately have, and I think really helps to smooth that transition process quite a bit.
Great, thank you. I always think back to when Dr. Nakamura was on, and what we used to call chemo brain, and now refer to more as different cognitive functions associated with cancer care, that starts at the moment of diagnosis, not when you start the chemo, but when you get that diagnosis. Well, thank you so much. Let's see, I think we are pretty much out of time, so I want to thank you for the questions that were shared. You know what? We're going to take this one last one because I think you'll be interested in that one. Where's the balance between informatics and building relationships with cancer patients?
Wonderful question. And I really, again, appreciate this question too. And I can think of some potential layers behind that question, because I think that I think that we can easily get sort of trapped in the allure of these complicated tools, wonderful data visualizations. And at the end of the day, I think that navigation is about human relationships. Cancer care delivery is about human relationships. And I think that really is the heart and soul of the navigation program. So when I think about balance, I think relationships come front and center. The informatics tools are what allow us to ensure that we are really helping to deliver these services in a fair, equitable, standardized way, that we're identifying people early. And we know that despite the best human interactions and relationships, sometimes there are things that are just not surfaced until down the road when we wish we'd known about them a little bit earlier. And that's what these tools allow us to do.
Great. Thank you so much. And thanks for that question. We want to say thank you to the people of North Carolina, the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, to you, Dr. Wood. We want to say thank you to Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all the hard work they do on each and every one of these lectures.